So Jason, for a patient who's had immunotherapy and let's say exhausted all available immunotherapies and they have a BRAF mutation, they're on BRAF inhibitor-based treatment, they've responded for a time, they're now starting to progress. Treatment beyond progression, I mean, is this without available therapies to reach for otherwise, FDA-approved treatments, is that a reasonable proposition for most patients, all patients?
With BRAF inhibitor?
Yeah.
I think it's individual patient level decision. What is the progression? If you have where you can intervene somehow on that tumor, then absolutely. If it's widespread systemic progression, it's not like immunotherapy where we think there might be a little something here.
Yeah.
But absolutely in the context of an isolated lesion, a couple of lesions. At our site, we have a very active radiation oncology group who will do multi-site stereotactic body radiotherapy. And so even if a couple mets start to grow, we can get them. So I think that's very reasonable. But again, I think that's a patient level consideration. I think unfortunately, we have many patients who get past PD-1 and they progress systemically in BRAF inhibitor, and we still have to employ chemotherapy in some of these patients. And I don't think it should be lost sight that that does still happen sometimes for some patients.
Yeah, and then just a quick last point. So if a patient had a BRAF mutation, received BRAF/MEK upfront therapy, ultimately progresses, moves to immunotherapy, ultimately progresses, any role to go back to BRAF immunotherapy?
Absolutely. Absolutely. So this is something that we do in clinical practice quite a bit with my sort of network of folks that I work with. We have patients who are BRAF mutation where we know that works. The question is, how are we going to use that optimally? And we often will use it to maximum benefit and take patients off if they've already progressed through other things with the hope of getting them on a study, knowing we can go back. And we will do this intermittently with the idea to try to keep the patient in good shape as long as we can to get them as many chances as we can to other options.
Yeah. All right, no, that's great. I think, of course we need targeted therapy options for other patients. We're starting to get a little bit of a glimmer. Maybe we can get a foot in the door there. So how do you look at this emerging binimetinib MEK inhibitor monotherapy data, Georgina, in NRAS-mutant patients? I mean, is that a therapy that is interesting and maybe a building cornerstone for combination? Is it actually a therapy that, based on the emerging evidence, actually could be endorsed in practice?
So based on the emerging evidence, and that's the NEMO study, the phase 3 trial of NRAS-mutant, it was only Q61 NRAS-mutant melanoma, randomized to dacarbazine, versus binimetinib, the MEK inhibitor. And I don't think this trial will change clinical practice at all. There's a benefit with progression-free survival, there's a benefit with response, but there's no benefit with survival. So, but it is a wonderful foundation because there's definitely a signal there. It's a wonderful foundation for combinations. And I think MEK inhibition is a good basis because the MAP kinase pathway is overactive, constitutively active in the majority of melanomas, even if they're not BRAF mutated. Yeah. So I think it's a good foundation. It is a building block, definite PFS and response rate advantage. It's something we now need to understand more. As we started this whole discussion with, when we were talking about mutations, we need to understand better the pathways and how to inhibit them. But MEK inhibitor is a good foundation to add things on to.
Great.
And could I just very quickly, because we raised it in the beginning about other molecular targets, and one that we didn't discuss because isn't quite ready for prime time in melanoma, but maybe is in breast cancer, and others is CDK4. Yeah. And so there was data here at ASCO around CDK4 being important in some of the other melanoma subtypes, but again, as an add-on in the NRAS space, it looks like regulation of the cell cycle machinery as a secondary threshold in most melanomas probably actually is a good combinatorial partner. And building on this MEK data in RAS mutant tumors, I think that's the obvious next step. We have some data already in this space, and I think that you'll see that coming forward very soon.
And CDK2NA, which is another, that whole cell cycling mechanism is quite common in melanoma. I agree. I think the combination of MEK inhibitor and CDK4/6 inhibitor, which has been explored in phase 1 in NRAS, is probably great could be extended to other types of melanomas other than just NRAS, but definitely something to watch.